All right, dear friend, thank you again
You're welcome.
for doing this. Could you just introduce yourself and a quick background on you?
Sure. Yeah. So my name's Emily. I've been an occupational therapist for 7 years, mostly acute care. Worked in acute care for about 3 years, then transitioned to float pool, being inpatient rehab with acute care um, for about a year, and then back to acute care for now another 2, 3 years. I don't know if the math adds up. Um,
Okay,
but yeah.
it's fine.
Big,
We don't.
big acute care gal. Love me some cardiothoracic surgery and neuro, but you know that.
Yep, Cabbage Patch Kids.
Mm-hmm.
Okay. So I know I shared with you that list of assessment tools. So are there any that you use for an eval or anything?
Yeah, so especially with neuro, one of our in our eval section obviously is tone. So if they do have deficits in tone, modified Ashworth comes up, and we can click through that, whatever is appropriate for the patient. So I would say using that a good amount of time, probably with every neuro ICU patient at least.
Mhm.
Um, in the acute care setting, I would say out of that entire list, the one I'm using the most in terms of like formal assessments of sitting down, doing an assessment with a patient would be the MOCA.
The mo-
Um, a lot of, doctors putting in orders to complete a MOCA to it's either to ensure capacity for patients to make decisions, or a lot of times someone will be very physically independent, functionally can do mobility, and that's a lot of what the doctors care about. But if OT is recommending sniff for cog, we will do a MOCA to really hammer home why we're recommending sniff when on the outside they might look pretty independent, but they got a lot more going on under the surface.
yeah,
Mm,
the walkie-talkies.
yeah, yeah, but then you talk to them more and you're like, oh Lord. Um, yeah, the Barthel, we do have um, we can do that assessment in our evals as well. I'm not the biggest fan of it, to be honest. I like the modified Barthel better, just because
Okay.
I feel like the Barthel, it's either one or the other. They're either independent or dependent. That's kind of the only ones you can click. Where modified, it still doesn't give you a whole bunch of options, but there's more grading to it than the Barthel at least.
Oh,
Um, and then I used to use the short bless test a lot. I've kind of gotten away from it. I don't know why, but that's a really good quick one, cog to use in acute care. Um, and I don't personally grade GCS, but we look at GCS all the time. The neuro docs are constantly putting GCS,
right.
or H&Ps always have a GCS. So, really have any awareness of that one, not necessarily to me measuring it, but knowing the different scales and everything.
Okay, that makes sense.
Hmm.
And I know you said you have a little bit of inpatient rehab experience. Did you use those same assessments or was there something, other ones that you used in that setting?
I mean, what we used for I think they were moving away from the FIM once
Yeah.
I was in IPR, but I don't know if they have a certain name for those GG scores. I think
Oh,
it's based off the FIM, if I understand it correctly. But same, I cover the skilled nursing unit sometimes at the hospital. We use GG there. We
mhm.
use GG at IPR as well. So I don't know if that's a specific one, but
I think that's good to mention
yeah.
because if you do use other ones that aren't listed, that
Hmm.
that would have been the follow-up question.
Hmm.
Um,
But I know since I was float pool and PRN, I wasn't having like a consistent caseload to
mhm.
do really formal assessments. I know that a lot of the primary OTs would do formal assessments, and obviously there's so much more IPR. Like, I remember they had the 9-hole peg test. medication management. Well, I don't know, remember exactly what it was called,
Okay.
but like I'm sure they have the Kels and all that. I never really utilized them
Yeah,
because I was doing treatments a lot too, as opposed to evaluations.
I see. With being float pool,
Yeah.
right? Okay,
Hmm.
that makes sense. But that's what you were seeing in like other evals.
Hmm.
Okay. Okay. Um,
And I'm sure there were a lot more, but I just can't remember off the top of my head.
okay. And could you like quickly like give a synopsis of what GG codes
Yeah. Yeah.
are?
So, even at the SNU, at the skilled nursing unit at our hospital, at IPR, you would have to fill out a GG score for admission and for discharge. So all that was it went over every ADL. So I'm thinking of what we've done at the skilled nursing unit: grooming, personal hygiene, self-feeding, bathing, upper body dressing, lower body dressing, and footwear. And you would have to score each one on eval. There were different kind of grades of scoring, so it went from no physical assist, incidental touching, which I just think of as contact guard,
Yeah.
then physical assist, and then if you hit physical assist, you have to, it gives you like less than 25%, 26 to 50%, 51 to 74, and then 75% plus, and you have to kind of click where they're functioning with each one of those ADLs. And then you want to do like a goal of where you want them to be as well when they're um, you hope they'll be at discharge, and then you fill it out again at discharge.
Okay. It does kind of sound like FEM a little
Mhm.
bit.
It's just like I think they just changed the wording, and instead of like contact guard min mod max total,
Mhm.
it's that total is like 75% or more of
Yeah.
the entire task, that 51 to 74. It's basically the same. It's
Right.
just I don't really know why they moved to it, but that's how I think of it. It's
Yeah.
on max.
Yeah. Okay. Because that's how I would understand it, just with how.
Hmm.
Okay. So when you were primarily doing these assessments when you weren't float pool, how did you decide? I know you kind of touched on that, like, but how would you decide which assessment to do versus another?
Um, I think in inpatient rehab, it was easy. You just have to do the GG with
Hmm.
every single admission. In terms of acute care, obviously doing formal assessments, you're so much more limited because our sessions are shorter, the turnaround time is just so much quicker. Um, a lot of times it just, again, depends on discharge, like we're trying to back up our discharge recommendations. So
Yeah.
I would say that's my main decider, especially like doing a cognitive eval, a MOCA versus a short blessed. Um, a lot of times, when we're doing the modified Ashworth of doing tone, we're really backing up why does this person need IPR if we're recommending it. Um,
Mhm.
so, and then it's just kind of good to great. Like the the Barthel, we can do with every session. And then we didn't even touch on this, and it wasn't even on the list, I don't think. The AMPAC.
Oh, yes, the impact.
The AMPAC, how could we forget? Sorry, I'm
No.
getting a pass firing. Um, we might
Yeah.
be having a guest to the Zoom in a little bit, depending on how he reacts.
Okay.
So in doing, we like to fill out the AMPAC with every um, eval treatment in acute care. It's a quick assessment just to kind of see how they're progressing while they're in the hospital. See, can we upgrade them to home health instead of SNF? Can we do home with no needs? Do you want me to explain the AMPAC a little bit?
Um, yeah, I think like a quick
Yeah, it's just, I mean, it goes through just your major ADLs. So bathing, I don't remember.
it was bathing, toileting,
Mm-hmm.
upper body dressing,
Body
lower
dressing,
body dressing.
lower body dressing, feeding, grooming.
Rooming, yeah.
On a scale of 1 to 4, one
Mhm.
being they need total assistance with that task. No, one being, yes, one being they need total assistance with
Mhm.
the task, 4 being they're completely independent, 2
Yeah.
being little assist, 3 being a lot of assist. So that's an easy, sorry, buddy. That's an easy kind of quick assessment, especially to do in acute care.
Yeah. And I'll add, I know this is probably more helpful for case managers. Like if they're under 18, they need
Right,
to go to a facility.
right,
If,
right.
um,
Yeah,
and above 18, maybe like home health. Um,
right. Yeah.
one thing that's interesting about the AMPAC is a while ago, an OT that used to work at the hospital, she did like an in-service on it.
Hmm.
Just how like with toileting and feeding, like if they have any like alternative means of nutrition, they're always a one.
Right.
Like with
Right.
toilet, they have an ostomy or a catheter, they're always a one.
Hmm.
Doesn't
Yeah.
really tell the full picture,
Yeah. Well, I didn't
but
even
then it
know
kind
that
of it's weird.
someone has tube feed, but only nocturnal feed.
Right.
Can you still grade, what they're doing during the day? That should be a yes to me, but does it,
Yeah.
is it a little ambiguous to them, So,
Yeah, that's the only thing I don't like about the AMPAC. It doesn't tell the full story when it comes to that stuff. But you're right, it is super quick,
and
easy.
then I know there's like some discrepancies that people have between it. So,
Mhm.
like for me, if someone is set up for feeding, that to me is already a 2. To other people, which would be like, a little help, where I think to some people, it's the physical task of fork to mouth. So they would grade, even if they were set up, they would grade feeding as a 1. So I think it's not, I mean,
Or you mean the opposite, like three little, because four is independent.
yes,
Okay. No, you're fine. I'm
all
catching.
that except the opposite. So someone would grade, if someone was set up, but they can bring food to mouth physically, someone might grade them as independent, where me
Right.
personally, if they're set up, that means to me they need a little help. So,
I would agree with your how
mhm.
you look at it.
But yeah, I mean, I think it's a little bit more in can it be interpreted a little bit more than like some very strict, like reading from a script assessments.
Yeah, yeah. And I know you brought up the mocha, and I feel like that's kind of like the closest to reading from a script that we do at
Mhm.
the
Oh
hospital.
yeah.
What have you found like limitations to that? Like with administering it to an acute care patient, do you feel like, or there are things where you feel like it's not, how can I say this? Like not the most standardized because of just the
Oh
environment?
yeah. Yeah, I mean, with being in acute care, I always think of it as rehab and therapy are kind of secondary in acute care, and medical attention or medical stability is number one. So if
Mhm.
I'm doing a mocha, and I'm in the middle of it, but doctor comes in, does a whole spiel, and then it disrupts the flow. Sometimes we have family members in the room who are giving little hints in the corner, um,
Yeah.
which isn't helpful. Sometimes I have found myself that a doctor will order a mocha for someone, in my opinion, who's really not appropriate for it. Like not even A&O times one or oriented times one, excuse me.
Mhm.
Um, so I'm going in and I'm trying to read from the script, but they can't even focus on what I'm saying, let alone following my directions. So
Mhm.
I find myself kind of sometimes simplifying the directions,
Mhm.
which would in turn alter the results.
Yes.
So yes, definitely. Yeah.
Yeah. Acute care is messy.
Mhm.
We probably answered this already, like with talking about the impact. That gives us an idea of their occupational performance. And I feel like, well, what do you think? Like the mocha, it does, but like more indirectly on how they could approach. How would you take that as far as like using the mocha to determine or assess someone's occupational performance?
I mean, it wouldn't be my go-to,
Right. Yeah.
because I just feel like it's looking I mean, again, someone can do a 30 out of 30 on a mocha, but then be max assist for all their ADLs. You know what I
Right.
mean?
Yeah.
So, I mean, I, yeah.
Yeah. It can't, it shouldn't be a standalone, pretty
And
much.
yeah, it's never going to give you the full picture of the person.
Yeah. Okay.
I think I don't know if any assessment that I have done a lot would. I think you need to use things together as well as observation and your clinical judgment.
Mhm. Yeah, I agree. I agree. So this is a fun one. I know you have your degree. When's the last time you like reviewed like journal articles or like use them to support why you're doing what you're doing, even if it's not a formal assessment or just showing the doctor like, hey, this is the evidence as to why I'm making this clinical decision.
Yeah, so me and a PT have recently been, she's kind of taking primary and I'm just kind of helping out. But wanting to kind of update our, um, I don't want to say framework, but for critical care, I think there are some advances we can make with mobility with those patients. So, for instance, I'm a cardiac queen. Right now, like if someone has an femoral sheath, intra-aortic balloon pump, Impella, any kind of device that's inserted femorally or anything like that, it would be like a hard hold, don't see them. So, we're trying to kind of shift the perspective and how we're thinking about mobilizing these patients. So we've actually found a lot of articles on the benefits of mobilizing these patients quicker and how to do it safely in terms of get them over to a tilt table, bring the
Hmm.
tilt table up, and then kind of walk from there. Or, do any, I mean, I'm thinking more of early mobility as opposed to ADLs right now.
Right.
We're just kind of shifting the culture. So we were looking at a lot of articles on that. Like I said, mobilizing with IBP, importance of early mobility, mobilizing on CRT, all those kinds of things.
It sounds like again, kind of piggy, like going back to like acute care is kind of messy and not as
Mhm.
clean. And this will go because obviously people are going to watch this, Emily. So, but
Great.
it's okay. But
For the
I
whole class
know,
or just teachers?
but just like with learning about like OT's role in acute care, a lot of it is like preventing complications.
Right,
And I think you touched on that with the early mobility. So
right.
we're mobilizing for increased risk for like pulmonary decline, cardiovascular decline, contracture development, severe.
Muscle weakness,
Yeah. So
delirium
yes,
prevention.
delirium.
Mhm.
So I think that, yeah, it just kind of shows it's not as clear cut. It's like, it's more so like, let's push the function and not worry so much about these very formula or standardized assessments.
Goes back to what I said of therapy, as important as it is in the hospital, is definitely secondary to that kind of medical complexity, medical stability. So we can't be spending an hour with these patients to do an assessment. If I can work with an intubated patient, to kind of do simple grooming, bed mobility, getting them kind of at their highest function, both mobility wise and ADL wise. I'm going to focus on that more than
Mhm.
doing a big formal assessment.
Right. Yeah. And they get more bang for their buck, I think, also.
Mhm. And I also find that sometimes if you try and do one of these big formal assessments, kind of so acutely
Hmm.
in the early stages of their deficits or sickness or anything, you can find people might get more frustrated easily. And I'm sure that happens over the board, but it's like I'm kind of focusing on just being able to sit up on the edge of the bed. Why are you making me do serial sevens? You know?
Yeah. Yeah. Yes, that makes sense. And sometimes they're mad about sitting on the edge of the bed. Like, why are you making me do that? When it comes to like the evaluation process, when would you say it starts? And what do you feel are like the most significant elements of it?
For an eval, definitely getting their social background, prior level of function, home environment, who are you with, who's going to help you. It's on the population as well.
Mhm.
Because like I'm not going to do coordination testing with your med surge pneumonia, but
Yeah.
like with neuro coordination testing is one of the most important. Is same with sensation. Occupational profile, I would say is the most important, and then just kind of assessing mobility wise and simple ADL wise
Mhm.
where they're at and what we need to do to get them back to their prior level. Mhm.
Do you start looking for some of those key elements before, like say like their background and like do you try?
I will always some people um I think will really heavily rely on chart review to find prior level. So I don't really um search for it. Like I'm not going into a note looking at the case management note. I'm more focused on what they're here for.
Yeah.
Labs, imaging, all that kind of stuff.
And have you ever been in a situation where, say, you're doing an eval, the person, I don't know, say they're on the vent and they really can't answer all these questions? What do you do then?
Um Many things. If we're giving accurate yes or no,
Mhm.
not asking, thumbs up, thumbs down. I will really try and focus on yes, no questions. Do you live with anyone? Yes, no. And then I'll kind of try and look if see who do we live with, or do you live in a one-story home? Yes, no's. If it's not accurate, um, I will kind of abandon questions because we're not gonna waste time on all these questions that we're not kind of being able to process. And then
Right.
I will it depends on where they came from. I'll go see in a case management note and I'll say per case management, I'm always if I'm getting the information from somewhere else, I'm gonna say where I'm getting it from. Another thing that's really helpful is to look back at previous hospitalizations, seeing if there's any previous PT or OT note that I
Mhm.
can find prior level from or home environment. If
Mhm.
something comes from an ALF or a sniff, I will call.
Okay.
Really have absolutely no idea what their prior level is. If I can find it in the chart, I don't really call, but if I have zero clue, I'll call and find out. Family at the bedside is always helpful for the most part. That if I can't get any information, like you had a good example of someone like intubated on a vent, trach, can't talk. As soon if they get extubated and they're able to give me that information the next session, I can just put it in my treatment now. If it comes to worse, ask them when it's appropriate if it does.
Yeah. Okay. So it's like always gathering this information throughout the whole process. When you are like conducting the interview to get the occupational profile, if you had, what would be some key questions you would ask, or maybe recommend like a new OT to ask to get the most information?
A script in my head that I've been doing for 7
Oh,
years.
okay. Share.
So I always start with orientation. One, want to make sure I'm in the right room because there have been times that I've walked in the wrong room. So orientation questions, pain, and then I'll start with do you live with anyone at home? One story home or two, apartment, any stairs to enter, any rails? Are we independent with everything at baseline? Bathing, dressing, toileting, grooming, walking? Do we walk with any assistive device? Do you have any assistive device that you have at home but aren't using? Walk in shower, tub shower. Do we have a shower chair? Do we have grab bars? Um, and vision, hearing, handedness. And
Yeah.
that's then I'll kind of initiate bed mobility. I always like to test bed or range of motion and muscle testing on the edge of the bed as opposed to in bed. That's just my preference. I've tested range of motion manual muscle testing standing if the patient has stellar balance. Not
Mhm.
always the case. But yeah, I'll do all those questions, do bed mobility, do all my testing on the edge of the bed in
Mhm.
terms of muscle, range, sensation, coordination, vision. If they're a neuro patient, doing kind of more of a formal vision assessment of fields of vision, peripheral vision, and then I'll move to kind of mobility. And then I always like to, if we can get to the chair, I always like to do ADL testing in the chair, like lower body dressing in the chair as opposed to edge of bed because it gives them kind of that back support if they need more help.
Mhm.
Love walking to the bathroom if we can to do a toilet transfer. Love to offer people to do grooming because who knows how long it's been since they brushed their teeth. If I obviously you can't do every EL in an
Yeah.
eval. My thing I am always testing with every single eval is lower body dressing, you know?
Mhm.
So
Yeah, it's interesting, like your approach to like your evals, like what you assess is
mhm.
similar to how I approach a treatment when I don't know someone. I'm like, let me see how you move first.
Yes.
Can you do your sock? You know,
In neuro ICU, that is one of those times if someone's completely hemiplegic or hemiparetic, and I'm trying to really get a good sense of their muscle testing, I will test those patients in bed. Because
right.
once we get on the edge of the bed and balance is an issue, neglect is an issue, with those neuro patients, there's so much more going into sitting on the edge of the bed.
Yes.
I want to get a very formal manual muscle test with a lot more muscle groups. I'll do it in bed.
Hmm. Yeah, no, again, same. Like if,
Yeah.
I'll like say I'll read your eval and I'm like, okay, they were like a 1 out of 5 on their right arm. Let
Mhm.
me just see what it is today before we
Right.
even
Do
get
we have
to,
anything improving? It
yeah,
also gives, like I said, for neuro patients specifically, kind of gives you a good sense of how is this supine descent going to go. You
right. Yes,
Mhm.
yes, absolutely. So, and with that, when you were doing IPR, when you do evals in the SNU, do you follow the same formula or is it a little, or are there like little differences that you
I
would do?
do more. It's definitely a different beast. IPR, every eval was blocked off for 2 hours, and it
Oh,
was expected to do every ADL in every evaluation. Ideally, getting in the shower. If absolutely a shower is not appropriate, at least bathing off at the sink, doing an entire bath, not just, hot spots.
yeah.
The SNU, we get about 45 minutes blocked off. Do a BIMS in the SNU with every eval, which that's another assessment I guess we didn't talk about. Just a quick cognitive one in terms
Okay.
of asking orientation, and then you have them say 3 words: sock, blue, bed. You go through your orientation questions. It's what's the month, what's the year, what's the day of the week, and then you have them repeat those three.
Yeah, I've done that before. I
Mhm.
think just it was something that happened and I did it and just gave the results to whoever the
I completely forgot we did the BIMS in IPR too. So it must be like a rehab big one. I do like to ask them if I do like when they have close from home. Most of the time on the SNU, they will, I would say like 75% of the time. So I always kind of push them to do dressing. Because again, I can use that dressing, both upper body and lower body, to kind of measure bathing as well. I know it's
Yeah.
different. Um, and then I do like, if possible, to like see if we can sit at the sink to do grooming because that's assessing balance,
Hmm.
assessing the ADL of grooming. It can be assessing COG.
Hmm.
So those would be my main differences of kind of, I think SNU again, I don't know how similar it is to like a skilled nursing unit or skilled nursing facility SNF. Um, but I'm kind of doing as many ADLs as I can. But like in IPR, we were required to do every ADL.
From when I used to work in SNF earlier in my career, I think it was similar, like doing what you can. for the eval? Because I think one job they did give you more time. They gave you 80 minutes, but then
Mhm,
it was more so like 50. So
mhm.
it varied. Like sometimes they would do like a full routine, like you would do an IPR, and sometimes it would be like, well, let's just see what we can do, make it as functional, see what you can tolerate.
Yeah, I would say for the most part in IPR, 2 hours was really good. Like, I would be able to do everything in that 2 hours. If I did had like a higher level patient and it just took an hour to do that stuff, we could then go to the gym and do like neuro re-ed. We could do like more of your simulation type
Yeah.
therapy stuff.
Yeah.
And then one time I remember I had an eval that took me 3 hours when I did every single thing. So you
Oh, wow.
think 2 hours is enough, and then
It's not.
is
Okay.
yeah.
So I guess to kind of wrap up what you said in the bow, so like acute care, when you're doing an eval, you're
Mm,
more so looking at, you might start with the performance skills. So like looking at sensation, cog,
mhm,
coordination, strength.
mhm.
Whereas in IPR and even skilled, you're gonna start with the task itself and then maybe break it down. Is that
Yeah, I mean, sometimes, honestly, sometimes in SNU, I will forget to do manual muscle testing because I'm just jumping right into it.
mm-hmm,
If someone has that like hemi, where there's gonna be a big discrepancy on either side, and I'll test it more. But a lot of the times, these SNU patients are like generalized weakness,
mm-hmm.
so we're gonna be weak. I'm more focused on, like you said, the functional tasks than me going through every coordination, strength, range of motion, sensation, vision, hearing. I mean, I'll do like, do you wear glasses?
Right. Yeah, yeah, yeah.
I'm
You
not
have
gonna do as much of like going through every little step.
okay. Very good. I think that was great. Thank you. Is any final thoughts or tidbits?
I don't think so. I'm a talker. I probably